Yo, yo, yo. Hey, guys, welcome back to another awesome edition of the Best Practices Show. Have you ever thought, what does the lab say when I send over these scans? Well, today, we're going to tell you what they say with my dear friend, Dr. Christian Coachman. And he goes through the 15 nightmares of every lab when you scan. So please listen to this. I hope you guys enjoy it, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. I've got a great one for you today. Have you ever thought, what does the lab think when I send this stuff over? Well, we're going to go right there today with my dear friend, Dr. Christian Coachman, in our ongoing series. And we're going to talk about the nightmares of every lab when you send your scan over. Christian, welcome back, my friend.
I love this topic. I'm going to be able to put my lab technician hat and just complain about dentists all over the world, pointing fingers. No, I'm just kidding. The goal is to actually identify these bottlenecks, pain points, limitations, mistakes, problems, with these files that we get from scanners. As we know, the scanner is the gateway to the whole digital workflow. And that's why I think this is such an important topic. And that's actually the reason why we are putting a course together only about this. The iOS Festival, the DSD team, myself, of course, with the Anini brothers that are among the best digital experts in the world. They have a digital practice that runs completely digital. They have 2 books that I was a co-author of one and wrote the preface of the other one called Digital Revolution. And they are lecturing about digital workflows all over the world. They have a very pragmatic, realistic approach to digital solutions. And we are getting together and creating this festival about scanners where we're going to discuss all different brands, comparisons, pros and cons, limitations, how to overcome them, strategies, workflows, in a very pragmatic, realistic way. 2 days in Modena, Italy, 100% focused on scanners. So we're not going to deviate to other topics. That's the key. So I love when you can really... I love talking about big picture concepts, philosophies, but I also like to balance with content and courses that are very specific, solving one problem, and not falling into the temptation of talking about everything, but just focusing on one thing. And that is how to master your scanner, how to take the best advantage of your scanner, how to have the best relationship with your lab because you're mastering your scanner and you're mastering the process of scanning and the preparation for scanning and the import-export of scanning and everything that the scanner can do for you. So I believe that this is a key aspect of becoming a modern dentist, right? The same way that a restorative dentist since ages have to master impressions in general, bite registration in general, the scanner actually plays several roles, right? In the beginning, we would say that the scanner was the substitute to the impression, but we know it's much more than that. So it's a documentation tool, is a diagnosis tool, is a patient communication tool, is an impression tool, is a bite registration tool, is an occlusion examination tool, is a patient education tool, is beginning of the ortho workflow, is the beginning of the restorative workflow, is the beginning of the implant workflow, is the beginning of the perio workflow, is the beginning of the orthognathic workflow. So the scanner is all of that, right? So mastering the scanner means that you are mastering all these initial steps of all these workflows. And the same way we would say that the quality of the impression would dictate the quality of the whole restorative workflow, the quality of mastering all the scanner tools will dictate the quality of all of these things that I just mentioned. So it's a must.
Yeah. So, Christian, you mentioned the word gateway. And if you're a
Mhm.
dentist listening, you're thinking, oh my goodness, I just purchased a scanner. We're learning. So, it's an important tool, it's an ever evolving tool. You're privy to a lot of information. These scanners are getting smaller, they're moving
Mhm.
faster, and we need a better ROI. So, help us
Yep.
through this.
So companies are doing their job, doing their homework, investing on improving scanners. You know, you can compare with 5 years ago and already see a huge difference. And in the next 2 years, even a more drastic difference. It's going to become easier to scan. It's going to be faster to scan. It's going to be easier to connect the files with the rest of the files of the patient and create the patient avatar in a more automated way. It's going to be easier to access this information in the cloud. Everything is going to be cloud-based, and you're going to be able to connect to the information from anywhere in the world. You're going to be able to improve your communication with your orthodontist, your periodontist through the information that the scanner will provide and automatically drop into everybody's phone. So you're going to be able to do asynchronous communication and visual communication better through the scanner. So it's exciting. It's exciting to see how the scanner is going to help us with challenging aspects of diagnostics, treatment planning, case acceptance, and clinical execution. But we still need to be a great dentist before that, right? Scanners will not do any magic in terms of fixing our mistakes. We still need to know how to prep teeth very well, how to manipulate the tissue so we can see the margins, control the bleeding, control the saliva. We still need to be able to control the position of the teeth, to be able to make the ideal preps and scans. We need to be able to control the bite registration. We need to be able to control how to deprogram a bite, how to take the jaw into centric relationship, how to stabilize the jaw in that position so we can scan the right bite, right? So by knowing that, by having a regular lab and working as a regular technician for 20 years myself, analog technician for 20 years, and then for the last 10 years owning a digital lab, we are able to see a lot of volume coming, many cases coming from all over the world, different scanners, different doctors, and we are able to see the most common mistakes, the most recurring problems, the most common limitations of the process. So when we had the idea of putting this course focused only on scanners, I told the team, we need to start from the problems. Like I always like to start putting my lectures together. What are the problems to be solved, right? So I brought the team together and say, please list me. Give me a list of the most common mistakes. I went to my quality controllers. We have people here in the lab that their job is only to accept the information from the dentist, organize the information, and evaluate the information, right? And then if they see any kind of yellow flag, they call the senior controllers, the mentors of the team, to come in and evaluate to see if we can accept that, or should we send back to the doctor and say, doctor, unfortunately, this is not good enough. You need to fix this by doing X, Y, Z. And that's something that hasn't changed from analog to digital. many times I mention in my lectures that there are research, historical research showing that unfortunately a big percentage of cases that are sent to labs should be denied by the lab. The lab should be saying no to dentists. Actually, at the majority of cases that are coming from dentists to labs, unfortunately. There are surveys showing that, most of the preps going from dentists to labs shouldn't be accepted by the labs. Most of the impressions coming from dentists to labs shouldn't be accepted by the labs. If we draw an ethical, common sense, quality standard line, right? We would get to that conclusion. When it comes to preps, impressions, and bite registrations, I can even say from my own experience that around 2/3 of these bites and preps and impressions are below the line of a decent standard of quality. Now, I'm not saying this as a technician to blame dentists blame dentists for all our problems. It's just to realize that preps, impressions, and bite registrations are just very challenging to be made. And we underestimate how difficult these things are. We don't talk enough about it. We don't put enough effort to become better at it. We try to pretend that these three things are under control, and they're not. The thing is that the human body is so amazing that usually at the end, when we deliver our work, the human body has an amazing capacity to adapt to our mistakes and limitations, and things tend to just work. If I'm saying that 2/3 of the cases shouldn't be accepted by the lab, at the end of the day, usually 2/3 of the cases end up working pretty well despite all these limitations. So it basically puts us on the comfort zone, right? My prep is not ideal, but it's going to be fine. The bite registration is not ideal. It's going to be fine. Impression is not ideal. It's going to be fine. But as a technician that always liked to pursue high quality and be very tough on myself and really go for the details and challenge myself, I was never, extremist, meaning only perfection, but I was always look for the balance between being reasonable, accepting that things are not ideal always, but at the same time not get stuck on my comfort zone and challenge myself to improve the workflows and do better next time. And if this year I had this percentage of cases that were above my standard, next year I want to be slightly better in terms of the percentage of cases that are above my standard. Just natural evolution. So when it comes to digital, you bring these amazing technologies and the problems will still be the same. Preps and scans and bite registrations, the quality of the information coming from dentists to labs. I can add to this facial information and bone information and soft tissue information. So today, to build this ideal patient avatar, that's what we want. That's what the dentist should think. So I'm going to send the patient's avatar to my lab, right? I want the complete information in the lab. So not only the lab can do the best job possible that they can do, but the lab can also create this avatar to give me the visual information for me to analyze, diagnose, and treatment plan better this case and execute better. So we should always be, when we have a new patient, we should not only new patient, but new patients and patients on key moments of the treatment that you need to redocument the case. And you have very specific key moments of the treatment that you have to redo as if you were doing a first appointment. So scans, bite, CBCT, facial images, and that together creates the 3D patient or the virtual patient or the digitalized patient or the patient avatar, whatever name you want to call it, right? So a modern dentist needs to master the process of creating a precise patient avatar to allow the lab to work precisely on designing the devices and designing the restorations.
Yeah. Love it. So the limitations or the challenges to creating that patient avatar, what are they? Where do we start?
So specifically on the scanner, you know, as I told you, we were able to list 15 major problems, recurrent problems that we see happening every week in the lab, you know. And I can kind of guess that other digital labs around the world will probably make us very similar list. And we can go briefly through the 15 things because I think it's important for every dentist to start thinking about it or start dialogue with the lab about these things, and maybe technicians listening also to help them organize the problems, you know, because to create a solution, you need to be a master on the problem. You need to really understand a problem to create a solution for that problem. That's the first problem. People want solutions without deep diving on the problem. So when I told the team, let's create a list of problems, the thing is that it's not that easy. When problems are not that clear, and you can confuse problems, you can mix problems. You know, it's like a researcher, a very good researcher, when they are trying to identify the cause and consequence of something, and they have to fragment the problem into pieces because one thing can influence the other, and you cannot identify if this action is actually causing this problem, right? And you can get wrong answers, you can get wrong results of that research if you're not very good dissecting the problem and fragmenting the problem and removing the variables so you can just evaluate one simple thing, right? So when I asked the team, please give me the main problems that you're facing with scans coming from dentists, everybody was all over talking about mixing and already talking about solutions. And I'm like, we are not here to talk about solutions. That's the easy part. You know, we're going to organize the solutions. I want the 15 major problems that you're facing, or the 10 major problems that you see on scanners. And let's pick the right words and the right classification. You know, if there are 3 problems that are kind of overlapping, do they all become one problem? Or can we explain them better and they become important by themselves? So we divide it into 3 problems. And so this is the type of exercise that I love doing when I'm analyzing problems, right? And I think this is not only good for this course, it's good for life in general, it's good for business in general, it's good for dentistry in general, it's amazing for putting lectures together or creating speeches or addressing topics. When I say you need to start with the problem to be solved, it's an exercise that you need to do, or what are exactly the problems that we want to solve. And after you have this brainstorm that is all over, you have to clean up this brainstorm and come with bullet points. Do we have 5 bullet points? Do we have 10 bullet points? Do we have some bullet points that are so insignificant that they shouldn't be bullet points, or they can be incorporated to others? Or do we have a bullet point that is so big that should be break down into other 3 or 4 or 5 extra bullet points, you know? And that's the beauty, because as you go to this exercise, not only you become a master on the problems, you start to realize, oh my God, I didn't realize that this problem is actually this. This is the problem, right? My vision about the problem was kind of blurry. Now the problem is so clear that we can start organizing the solutions. We can actually start seeing if we do have a solution for those problems. And we realize that from the 15 problems, some problems we didn't even have a solution for it. But that's amazing to actually get to that conclusion, right? That some problems you have a clear solution, some problems we have a partial solution, some problems there's no clear solution. And this is actually also the best way for you to become valuable, or more valuable for the companies, you know?
Right.
These are the people that companies actually want to pay money and say, I want you to help me, help my R&D, help consult as a consultant, you know, advice for us. So it's good for you, it's good for your business, it's good for becoming more valuable for other companies to do this exercise of what are the problems to be solved.
Yeah. I love what you're saying. Totally picking up what you're putting down. We always say every business exists to solve a problem. The second one, you nailed it, is identifying really what the real problem is. And then the third thing we found it is when you solve the biggest problem, some of the other little problems go away.
Yep. Yeah. Because sometimes you see the team no, this is a problem, this is a big problem, and the other person, but this is also a problem. But then as you brainstorm and you clarify, you actually see that maybe 3 of the problems that we are discussing, they are all coming because of one problem that comes before that the real problem is this other one, not the one we were discussing. And if you find a solution for that real problem, the other 3 problems will naturally dissolve or disappear, right? Or be minimized in a way that becomes insignificant. So again, brainstorming about what are the real problems of my life, what are the real problems of my practice, what are the real problems of my management, what are the real problems of my marketing, what are the real problems of my communication strategies, what are the real problems of case acceptance that I have, what are the real problems that I have when doing veneers, what are the real problems that I have when working with my lab, and doing the brainstorm, writing down the bullet points, and then working on them until they become very polished, very clear, and straight to the point. So you can then, only then, sit down and say, okay, let's start working on the solutions now.
Well, let's go. Now, when you organize this, did you do them in order of importance or has it evolved?
I probably will, but I told you this is completely fresh out of the oven. I just finished this list a few hours ago.
Mm-hmm.
When you were saying, Christian, we need a topic to discuss today, I say, look, I just finished working with this. And we say, let's talk about it.
Let's do it.
I don't think there is, if you work very well on the problems and you come down to really significant problems, they usually don't necessarily have an order of importance. On our case here, talking about intraoral scanners, these are just problems that are directly harming the quality of the work if we continue with the work the way it is. They're going to harm the outcome, right?
Right.
So if you want, we can go through the list.
Let's do it.
So the first one is the poor mesh resolution, the quality of the mesh itself. The quality of the mesh is basically the quality of the surface of the file. How clean, how precise, how complete, right? How many details that mesh is bringing, or how many details the mesh is missing. Does the mesh has holes? Did artificial intelligence on the scanner try to fix those holes, kind of guessing those problems? And that's a problem as well. If that guessing is on a critical area of the scan, you may be fooled and think that the scan is good when it's not. So the quality of the mesh depends on the quality of your scanner, the brand of your scanner. It depends on the quality of the scanning technique, right? The scanning strategy, as they call, right? Every scanner has a slightly different scanning strategy, and you need to master the scanning strategy of the scanner that you're using. It also, the process of exporting, importing the files, downloading the files, you may lose quality there as well. Changing software, changing brands, so scanner from one brand, the CAD software from another, you may lose a little bit of quality on this movement as well if the scanner and the CAD software are not working well together. So labs, they need to be able to evaluate the mesh, know how to evaluate. How do you evaluate the quality of the mesh? How do you say no to the doctor if the quality is not good enough? And most importantly, how do you help the doctor, with strategies to make that quality better on the next one? So that's the first problem with scanners, with the problem with the quality of the scans. Another big one is scan distortion interproximally. This is very common on veneers, on preps that are touching each other, or teeth that are touching each other. They call it bridging as well. So you, if you don't follow the right strategy, you can create an area that is very blurry, or you can create artificial spikes on the scanner. And as you zoom in, you see that this is completely not realistic. It's something that the software created. If you don't carefully separate the teeth, slightly to create the finishing lines very visible. This is also happening on the junction between the prep and the gum. And you have areas that you have those spikes that you don't see where is prep, where is gingiva. And this is something that it makes no sense. It makes really no sense for a lab be seeing this and the dentist didn't see this before. Because this is something that the dentist needs to see chairside before sending the file. So if you give yourself a few minutes to analyze your scan before you send to the lab, you will identify, because it's the same file, right? So understanding how to visualize the files and evaluate the files chairside. Because this is the golden moment where you still have the patient there that you can rescan that area, right? So not pretending that you don't see those limitations, even though you're tired, the patient is tired. Understand the price you will pay if you try to work with that file that way, that open margin. You're going to get an open margin. You're going to get a misfit. You're going to get a lack of ideal morphology on that area. Something's going to happen. And sometimes you consciously want to take the risk, and that's okay. We do that all the time. Say, look, this is not perfect, but I think it's workable. We can work with this, right? So create those clear lines. And this is a discussion between the dentist and the lab. You together, you should ask your lab, make print screens of all the situations and areas that are not ideal. Let's sit down one day, go through these things, and let's discuss together what is acceptable or not, right? What is acceptable? Every time you see a finishing line like this is acceptable, go for it, right? Let's both consciously make that decision. But if we see this a little bigger here, let's stop. I'm going to do my best as a dentist to see this chairside, and if I don't, you see it on the lab, you just send me a message. We have to redo this. This is not acceptable. So create your quality standards with your lab by looking at the images. It's very simple, and I don't understand why people don't do that. Visual communication. Just tell your lab, even if you will accept my scan, everything that you don't like, make a quick print screen and share it on the chat with me. Just share it. And I just want to be exposed. I want to look at it. I want to get better. I want to understand the problem. Many dentists don't even know how to evaluate their scans. And it's so easy. You learn with your lab, because that's what labs do all the time. So encourage your lab to show the areas that are not good so you can learn with them, even if you're going to work with the file. So that's number 2, distortions at the finishing line, distortions in the interproximal area. And this means that the scanning strategy needs to be improved. The individualization of the preps need to be improved. Soft tissue management needs to be improved. Placing the cords and making the finishing line visible needs to be improved. So that's problem number 2. Actually connects with problem number 3, that is not visible finishing line. That's another thing that shouldn't be acceptable anymore in dentistry, right? Unless, you know, it's a conscious decision. You say, this is not ideal again, but we have to work with this for any reason. But the amount of times that dentists are, it almost feels like dentists are pretending they're not seeing. Like, doctor, I cannot see your margin here. And the doctor's like, no? How come? Say, look, this is the exact same image that you looked. So let's look together at this. Where is the finishing line here? There's absolutely no finishing line. The prep and the gum is becoming one thing, completely blurry. Now, if for any reason your patient has emotional issues, you already scanned the patient 10 times, there are limitations beyond your control, just anticipate the problem. Don't pretend you don't see it. Right? Don't like put the scan aside and say, I'm not going to even look at it. I know it's not good. Let's see if it's going to pass, right? Let's see if the lab is going to take it. Don't do that. Just say, look, on tooth number 9, on the distal mesial or distal palatal area, there's an area there that we cannot see. I tried 3 times. Just work with it. I'm anticipating to you, right? Do this, once you bring it to your CAD software, zoom in, give me an image. I'm going to draw with my finger here to you. Where is the most precise possible line here? But I'm already telling you, we cannot improve this area because of XYZ. I'm anticipating the problem. Have the courage to do that.
Right.
And it's going to be a much better communication, and the lab is going to respect you much more. And it's going to create accountability. It's going to make the lab want to work better for you. It's going to make the lab complain less about you. Nobody's going to complain if you already anticipate it. I had a problem here. This is not perfect. I'm already telling you. That's how we're going to work around this and get this done. And much better, much better. So this is also something that you as a dentist need to put the few minutes to analyze your preps chairside while your patient is still there. Make the notes. Create a report. Tooth number 8, there's a subgingival area that there's a challenge there. Tooth number 9, there's a part on the palatal distal where there's a little part that is not visible, but we're going to work around that. Tooth number 7, the prep is XYZ. And you go through this report. And nowadays, you have no excuse not to do that with AI. I'm going to give you the golden tip here. You download Loom, Loom, L-O-O-M, that records your screen, records your voice. So you're mirroring the scanner into your laptop. You're downloading Loom on your laptop. You're training your assistant on Loom. Every time you have a comment, not only for your lab, for your orthodontist, for your periodontist, for anybody, for yourself to remember in 1 month, whatever is important and relevant. You just say Loom to your assistant. Your assistant already knows, opens the Loom that will activate the screen if you want to record what is in the screen. For example, the scanner, you want to record the screen, you want to record your voice, and you want to record, press the button, and you start talking. You can talk while you're working in the patient's mouth. You can talk while you're moving the scanner with your fingers. And Loom is recording everything. You press stop. You have an amazing video that has your face and your screen. Beautifully automated AI will transcribe everything you said, will improve your English, will create a summary with the most important bullet points.
Yep.
And in one click is in the pocket of whoever needs to listen to that. If it's the lab, the orthodontist, the periodontist, whoever, yourself in 1 month. And Loom will even help people to answer and analyze the whole thing. As your lab is watching the video, Loom has pre-manufactured answers for whatever you're watching. And you press the button there and you create a chat inside Loom as well. Or you just copy paste the link into the chat that you use, WhatsApp, for example, that you use to communicate, and you solve the problem. So
Yeah.
this should be mandatory. You know, every time you scan a patient, you should do the quick report about the preps, the scans, and the bites, and the provisionals, and the facial information. So if you want, specifically on the restorative workflow, if you want your lab to be able to do the best job, you need to get the best information about the preps, the scans, the bite, the face, right? And the provisional. That's it. That's why you need to scan also the provisional, but you also want to comment about the provisional. You want to comment about the bite. You want to comment about the face. You want to comment about the provisionals with the face. You want to comment about last minute comments of the patient about the provisionals, the changes that you did on the provisionals. What do you want to keep into the final restorations? Do you want to copy the diagnostic design? Do you want to copy the wax up? Do you want to copy the mock-up? Do you want to copy the provisional? Do you want to copy the design that is already on the CAD software? You want a combination of all? You know, and the gum. The gum is also the sixth key aspect. You want to share the information of the gum with the lab. So prep, impressions, bite, face, provisionals, and gum. 6 pieces of information that we need in the lab to be the best possible lab for you. To become the best lab for you, we need these 6 pieces of information. Not only we need the information, even better, if you're sending the information with quick comments about possible challenges, limitations, how do you see to overcome, how do you want us to make the best out of the information. So this should be mandatory for a modern lab. This should be mandatory for a modern dentist to do. So
we use Loom every day. I use it 5 times a day. Even I love that. I even send it as an email. You know, I used to type emails. Now I just shoot a video and send it.
Exactly. That's it. That's the modern way of communication. And if you see that you're first, if you want to speak about something and you want the best copywriter, communicator to make you sound perfect, that is AI. That is Loom or other tools like that, right? So it's like having a copywriter, a marketeer, and a communicator, and an engineer, and a systems expert, project manager expert with you, taking what you said and say, this is the best way to explain it.
Right.
So, and then if you put on top of that, if you think about what you're trying to communicate and you ask yourself, can I explain better with images? Yes, many times, yes, you can. So let me connect my computer. Let me connect the pictures. Let me connect the images, my scanner, you know, my software, whatever, wherever, my management software images that I have, the x-rays, whatever that you have in terms of image, you bring it to the screen and you're talking to the screen. And Loom is putting everything together. So if you're a dentist and you're not using Loom still, you should start tomorrow because it's so easy. And this is actually one of the things that we teach on our courses as well, you know, on how to use these tools powered by AI to become more efficient daily, to waste less time and be more efficient communication wise, you know, create more efficient communication. Anyway, back to scanners.
Number 4.
Number 4, 5, 4 and 5. 4 is sharp angles. So we struggle with sharp angles, meaning preps that the doctor didn't see or pretended didn't see that there was a sharp angle there. That is not good. It's not good for restorations in general to have a sharp angle on the prep, but it's even worse for CAD/CAM restorations because of the milling strategy. So we want to make sure that the inside of the prep is smooth without sharp angles. And chair side, again, you can see that, right? We still identify too many sharp angles as we get here in the lab. And most of the times, we don't want to ask the dentist to reschedule the patient just because of a few sharp angles. So what we do is usually we create some spacing there that usually makes the restoration a little bit thinner on that area. Many times it's not a big deal. Sometimes it may be a big deal. And many times when it is a big deal, we don't see it as a big deal. And the restoration, instead of lasting 15 years, may break in 5 years, and we don't know why, right? So I would definitely evaluate chair side, sharp angles, and the scanner gives you the perfect condition because you can scan your preps, then you can put opaque color, not colored scan view, but the opaque that looks like a plaster model. And that's the perfect view for you to see how the shape of the prep is and smoothness and if you have sharp angles or not. And the other one is clearance. Clearance is pretty obvious. A classic nightmare for technicians. The amount of times that a technician needs to call the dentist in their career and say, "Doctor, there's no space." And it feels like after you are several years working as a technician, it does feel like putting the F in between. There is no and space, and between no and space, put an F there, right? Meaning there is no fucking space here. How can I work with this scan? And even though it makes technicians angry, I used to really understand the dentist because I was also a dentist. It's hard to evaluate clearance in many situations. But with digital workflow and a scanner, there's absolutely nobody to blame anymore but yourself. There's no excuse.
Right.
Because the scanner is giving you exactly the clearance chair side. So having the lab manufacture restoration without ideal clearance makes no sense. Not identifying that beforehand makes no sense. Not anticipating the problem makes no sense. And again, you can consciously say, I'm not going to prep more this tooth because of X, Y, Z. So I'm going to anticipate the problem and tell the lab, please build this restoration out a little bit. Or consciously say, I want to take the risk and make this restoration thinner in this area. Period. Is my call. Fantastic. Very courageous. That's what we need. We need people anticipating problems and making the right decisions at the right moment and taking the risks if necessary, but in a conscious way.
Right.
The other one, prep margins design. This is a tough one to manage without digital. This was a classic problem since always because it's impossible for the dentist when they're prepping a teeth, when they're prepping a tooth, to actually visualize exactly where the finishing line should be to allow the perfect emergence profile, to allow the restoration to have the design that we pre-approved. So there's a direct link between finishing line position and restoration design. The challenge is that we approved the design before the preps, right? With the diagnostic wax up or with the mock-up or with the digital design. So we have a design that we approve. We have the design that the patient approved. We have the design that we want. Now we want the prep to allow that design. So the prep needs to be guided by the design. And the finishing line position needs to be placed to allow the emergence profile to allow the design. Now, this was a huge challenge since ever because it was a big guess and you needed a lot of visual experience. You know, the dentist needed to have the 3D design in their brain and kind of, as they were prepping, try to envision the design over that prep in their brain and try to guess where the finishing line should be. So many times we would only be able to see that limitation in the lab. Now today, with the digital workflow, we can see that in advance. We can simulate the prep, we can overlap with the design, we can simulate on the software where the finishing line should be. So when you're prepping, you can be looking at these images in front of you to guide your preps. And then some scanners even allow you to overlap the design as you're prepping with transparency. So you're looking at the computer, you're looking at the screen of your scanner, and you can see your prep, your finishing line, and the future design already with transparency on top, showing you exactly where the problem is, allowing you to immediately go back to the mouth and change the finishing line, looking at the 3D image of the design in transparency over the prep. So this is the perfect world. So nowadays it makes no sense for the dentist not to leverage these tools to make sure that the finishing line of your prep is ideally positioned to allow us to design the restoration that you want, the restoration that your patient wants, right? So this is problem number 6.
Love it. Number 7.
Number 7, another classic one, undercuts, path of insertion. Man, oh man, the amount of preps that we get that have undercuts and no path of insertion, it's still too big. And unfortunately, to get mad to dentists again, there's no excuse. Because the scanner screen is there for you to look at it, and some scanners even give you the colors. Like, it's almost like having an alarm. The scanner is like, bang, bang, bang. Don't send this to the lab. There's an undercut here, doctor. Look at this, right? Orange towards red is an undercut. So we get too many preps with undercuts. And of course, as you know, if there is an undercut, we will either have extra spacing that will weaken the restoration, or many times the problem is that the undercut is close to the margin. So it means that we're gonna, if we manufacture the restoration will have a big open margin on that area, right? Creating leakage or creating a weak spot when it comes to longevity. Many times you're gonna make a bridge not fit at all, not be able to go in. If you're having 2 teeth that you're combining into a 3-unit bridge, you know, you need to have path of insertion combined between the 2 preparations, in between the 2 abutments. So you need to be able to evaluate the 2 preps or the 2 abutments in one image and ask the software to tell you, if I'm going to splint this one to this one, show me if there's undercuts here, right? So working as a surveyor on the old days to create the removable prosthesis, that you would place the model on that surveyor machine that had a vertical metal pin that would draw the model and show you the tooth equator, the equator of the tooth, showing everything that is north expulsive, everything that is south is retentive. It's an undercut. So the beauty is that scanners can work as surveyors and analyze your prep and show you where the undercuts are. So you can go back to the mouth, the patient is still there, and fix them. So it makes no sense to send preps that have undercuts to labs today. And still today, we get too many preps that have undercuts. Too many. It makes no sense. My question is why? Why do you do this? Why do this, right? Why take this risk? The patient is right in front of you. The scanner screen is right in front of you. It takes 1 minute to make that evaluation. It takes a few more minutes for you to go back to the mouth and retouch those areas. And it takes a few more minutes to rescan those areas and stitch the information, solve the problem. So let's work together and make this a problem of the past.
Right. Number 8.
8th problem we get from scans is that we don't get the ideal soft tissue information, the gingiva. So, as I said, to make your lab the best possible version of themselves, to allow your lab to create the best possible restoration. We have those 6 components of information that we need. We need great information on the preps, on the scans, on the bite, on the face, on the provisional, and on the gingiva. So the gingiva is obvious. A restoration needs to be in harmony with the gum. You have submergence profile, you have emergence profile, you have papilla shape, you have pontic areas, you have implant areas, and the restorations, they need to adapt beautifully to that tissue. So we need that information in the lab. Ideal world, that ideal integration between restoration and gum will be developed with the provisional from the dentist. So ideal world, the dentist is putting energy on the provisional and shaping the provisional. So finishing lines, pontic areas, black triangles are not there, emergence profile, implant profile, everything is solved with the provisional. So now what we want is to leverage our scanner to copy paste that information to the lab. It makes no sense for you to put energy on developing this ideal soft tissue with the provisional and not copy pasting that into the lab and having the lab start from scratch or have a wrong reference. So you need to capture the ideal emergence profile, the ideal papilla, and the ideal pontic area. That's it. So you need to capture the area around the prep. You need to capture the area around the implant. You need to capture the shapes of the papillas, and you need to capture the shape of the pontic. So you need to scan the provisional in the mouth, and the scan of the provisional in the mouth will already capture the buccal part of the soft tissue architecture. That's number one. Number two, you need to scan the provisional upside down outside of the mouth so you can capture the underneath information that the provisional was able to build. Because as soon as you take the provisional out of the mouth, the tissue will collapse. So scanning the tissue in the mouth will not give you the whole precise information. So it needs to become part of your protocol to scan the provisionals. If you did a great job with the provisionals, scan the provisionals upside down outside of the mouth. Give the lab that extra information. And also then put the retraction cords, open the margins, and then scan the preps. When you put the retraction cords, you remove the provisional, the pontic area is collapsing, the implant area tissue is collapsing, emergence profile area is changing, you're putting the cords, you're retracting the gum, you're changing the shape of the papilla. What I'm trying to say is that the scan that you do of the preps and the implants is not the gingival scan. The gingiva is completely distorted there. That's the prep and implant scan. So you need to do this other scan with the gingiva so we in the lab can use that information to design the restorations in harmony with the gingiva. So that's number 8.
Number 9.
Oh, that's the famous one. The bite. The bite. Wrong jaw relationship. Wrong bite.
Do you want to take a breath before this one? Because this is the one that makes you crazy the most.
They all do, but this one this is a tough one because it means that in the lab we're gonna design a full arch. We're gonna put all the energy scoping that full arch, adjusting that full arch, working with the digital articulator, adjusting excursive movements, protrusion, canine guidance. We're gonna then manufacture these damn restorations, you know. We're gonna adjust them. We're gonna make them look beautiful. We're gonna layer them, stain and glaze. We're gonna polish them. You know, the occlusion will be beautiful. We're gonna stain. We're gonna make them look natural. We're gonna put them in a beautiful box and send it to the dentist. And then you put it in the mouth, and the bite is off. And then you have two choices. One, destroy completely the occlusal surface and try to save the day by being a hero there and trying to, and then destroying the glaze, destroying the surface, trying to polish chair side, destroying the longevity of the restorations because you're increasing the chances of cracks and fractures because you're inserting fracture lines inside the materials. But you're still kind of nice to the lab because you're saving the whole mess by yourself. Or you're going to send back everything to the lab and say the bite is off. And we're going to say, but that's the bite you gave us. So that's the reason why it's important for us to balance the bite on the provisional phase, because then you can scan the bite with the provisionals as well on bigger cases, right? You also want to master the process of deprogramming the bite and registering the centric relationship if you're going to open the vertical dimension. You also need to master the process of registering the bite on edentulous patients, because if it's wrong, it's even worse because the whole surgical planning and restorative planning can be off. So mastering how to find the ideal jaw relationship and how to register the ideal jaw relationship. How to find and how to register is not easy, but it's key if you're doing full mouth cases, right? And it's key that you then use the scanner properly when scanning the bite, and you cross-check this by scanning the bite with the provisional as well, right? And then on the lab side, what is nice is that we can use some software tools that can help us identify if the bite is off and help us bring the models better together. So we can use software to actually create a better intercuspation between the jaws, right? Mount the models better. In the old days, that's what every experienced technician would do, right? We would get the models from the dentist. We would get that bite from the dentist. Many times the bite was distorted. We would try to mount, and then we would mount them using the bite from the doctor. And once we would close the models, it was off. It was like intuitively you could see, or from experience you could say, this looks not good, right? So many times what we would do, not to bother the dentist, we would take the models out and we would put the models together hand-free and try to find what is the best intercuspation for those models. Many times you would have a very clear intercuspation, and then we will remount the models like that, and many times that would be safer. So we have software that can do that as well. So that's something that every digital lab should have. But mastering the process of finding the bite, finding the jaw relationship, and registering the jaw relationship is key. And then learning how to leverage your scanner to scan those bites. And if you're not confident enough with that jaw relationship, create simple test drives, functional test drives. If it's a night guard, a bite splint to test drive that relationship. If it's some printed tabletops to test drive that relationship before you get into irreversible procedures. If it's a denture, printed cheap denture, just to test drive that relationship before getting into major planning, major manufacturing, and major execution.
Love it. Number 10.
Number 10. Oh, I already mentioned it's no provisional info, no scans and pictures of the provisional. I'm repeating this because this needs to become a key part of the workflow. You have to scan the provisionals, and you have to take the facial pictures with the provisionals. Dentists may say, but my provisional is not good. I did a provisional quickly. Don't take my provisional as a reference. Use the previous design as a reference. Say, doctor, that's not the point. We don't want your provisionals just to follow your provisionals on the design. We want your provisionals because The picture of your provisional and the scan of your provisional will allow us to stitch together all the rest of the information. So with the facial picture of your provisional smiling, the patient smiling with the provisional, it will allow us to match the upper scan of your provisional to that picture. The upper scan of your provisional will have enough information that will allow us to overlap the scan of the preps in a much more precise way. And since the provisional scan has the perfect intercuspation with the lower in the bite registration, we will be able to have the prep scan in the ideal jaw relationship with the antagonist. That's how we stitch the information. Sometimes we don't need to use it. Many times we do need to use this information. And so don't even think. Just give the lab the information and allow the lab to stitch the information better together.
Love it. Number 11.
Number 11. There was a subtopic on number 10 that is the doctor did send the scan of the provisional and the picture of the face of the patient with the provisional, but the picture is bad and the scan is bad. So that doesn't help much. So we need a precise scan of the provisional and with as much soft tissue as possible, right? We need reference. We need, scan palate always. You always need to scan the palate because you never know when you're going to need it to overlap the information to build the patient's avatar. So you need that information. So the next one is for implants now. Scan body wrongly scan. No, first one. There's 3 now. 10, 11, 12 are all related to scan body. Number 1, there's noise. There's noise on the scan body area, scan body region. This is something that you can see chairside as well. So if you're doing an implant with the digital workflow, the quality of the image of the scan body that you capture is the key to overlap everything. Otherwise, you're going to place the implant on the wrong place. So you need to make sure that the scan body image quality is great and sharp, and there's no noise, meaning there's no things that look like whatever on top of it, right? It's a clean, precise image. So scan noise is one. Scan noise over the scan body region. The next one is wrong height of scan body, meaning picking the wrong scan body to scan. We're going to talk a lot about this in the course. And the third one about the scan body is scan body wrongly scanned or placed, meaning that the scan body is not completely fitting in the implant or is rotated, it's out of position, or is the wrong size, or there is noise on top of the image. These are the most common mistakes, problems that we see with scan bodies. So that's 10, 11, 12, 13. Oh, there's one more. Poor choice of scan body.
Okay.
So you need to learn from your lab what it means, a good choice of scan body, or learn from the companies or from the lab or from experienced digital clinicians what it means to choose the right scan body and what it means a poor choice of scan body. There's even different brands, different situations, different scenarios, and you need to understand that because that will dictate the quality of the whole work over implants if you do digital. And the final one, full arch scan distortion. So no passive fit on the restoration or on the passive fit test. So we know this is a challenge. We know that this is a big topic on scanning. This is the ultimate challenge to be overcome in scanning situations, right? Scanning a full implant arch and having precision to fit milled restoration with passive fit. So that's a real problem, but we have different great solutions for this today that makes us be able to scan any scenario, any situation, and do it fully digital. We don't need to do the old school analog high precision impressions of full arch implants. And this is amazing because these high precision impressions in the analog world were a nightmare. They were crazy, insane techniques to try to transfer the precise position of the implants to the lab. And so many things could go wrong that being able to scan multiple implants with precision is huge. And today you can. There's different strategies for it, and we're going to show it in the course.
Love
These
it.
are the 15 nightmares for labs regarding scans.
Yeah, I have so many questions, and I know we don't have time for everything, but Christian, percentage-wise, how many team members do the scans versus dentists? Just from your guess, would you guess? Because if I'm a dentist listening, it's a lot.
Mm-hmm.
But what's amazing is when you can teach a team member to do this.
So depend on what scan. So let's divide between. Actually, we're gonna talk about scans in 6 levels in the course that will answer your question. Scan level 1 is scan for diagnosis, communication, and ortho workflows. It's basically the diagnostic model. Of course, much more simple. Then you have the scans for partial implants. Then you have the scans for hybrid cases, implants and teeth, a little bit more complex combination. Then you have the scans for big veneer cases. That's level 4. Then you have the scans for full mouth rehabilitation. That's level 5, extra challenges. And then you have the scans for full mouth implants, extra layer of challenges, level 6. And level 7, scans for removable, different challenges, different strategies. So you have basically 7 reasons to scan, 7 scenarios that require 7 different strategies and 7 different workflows. So I would say that level 1, diagnostic models, communication and ortho models, almost 100% dentists are not doing, just the team is doing those scans, right? First appointment scans, hygiene appointment scans, ortho appointment scans. You should save time and just train your team to do that. Partial implant scans is the second easiest one because you don't have preps, you don't have finishing lines, you don't have gum covering the margins, you don't have to work with the gum around the preps. So it's definitely something that an assistant can do and should be doing. I don't know the number exactly, but probably 1/3 of dentists are actually exploring that already, and they should explore more.
Right.
Now you get level 3 and 4 and 5 are scanning preps over teeth. It's a little bit more complicated. You need to understand what you're seeing and the prep and where is high definition, but everything is purely technical. There's absolutely nothing here that you cannot train an assistant to do. And if the assistant is more careful and the assistant takes better care of the process and the assistant can handle better the patient on that moment, the assistant will be scanning much better than the dentist.
Agreed.
Period. And then you have the full implant, level 6. This is a little bit more tricky because you're scanning the soft tissues around and you're covering the vestibule, and you're trying to move the tissues to get the information. But again, if you train somebody to do it, whoever is doing the most will do the best. Whoever is doing the most will do the best. There's absolutely nothing on none of the 7 levels of scanning that you say you need to be a dentist to understand how to do it. Nothing about the scanning process that a dentist should know. that
Yeah.
it should be done by a dentist because the dentist knows something that hygienist or assistants or a technician wouldn't know.
Yeah. Now you're going to take these 15 problems and during your festival today, talk about countermeasures or solutions to all of them, correct?
Yeah, so that's the reason for the course. That's the why of the course.
Right.
You have these 15 problems, and we're gonna show how to overcome them
Yeah.
or minimize the chances of problems.
Yeah. Talk about the vision of this course just a little bit more. This is something you want to do annually or regularly, right?
So this is we used to do that I would say 7-8 years ago when scanners were just out. And this is gonna be our first one now on this second moment after several years. And we want to do this annually. Every year, doctors coming from all over the world. We're gonna have all the major brands. We're gonna have major experts on each brand to take the best out of each brand, each model, so we can have a very good comparison, brainstorm, discussion. I'm gonna work as a moderator on these discussions. We're gonna have a survey at the beginning where we're gonna be able to evaluate the level that each participant is. Basically, on the 7 levels that I mentioned, we're gonna ask three questions. Which scanner are you using for this specific level? Are you confident with your scanner at this level? What would you like to improve or see the company improving in this level? So this is gonna guide the whole discussion, right? From the more simple level 1 to the most complex level 4, 5, 6, and 7. We're gonna understand where everybody is at. We're gonna understand what they would like to see improving. This is also gonna be able to allow us to generate reports back to the companies to help them further develop their solutions. And we're gonna have hands-ons as well. They're gonna all get models, and they're gonna be able to practice different levels, different scenarios with the scanners, following the techniques and strategies that we were suggesting in the course. And they're gonna see a live patient as well, where the Anini brothers will demonstrate some of the technique in real patients in clinical situations. We're gonna have, of course, lectures about the 7 levels, and we're gonna show the complete workflow step by step, detailed step by step of each one of the scenarios and how to better use the scanner in each one of them.
Yeah.
And it's gonna happen
Awesome.
once a year, always on the same period of time, because this is the best part. The course is gonna be every year. The DSD team and the Anini brothers, plus major guests, in Modena. Modena is the capital, is the city, home city of Ferrari, is the home city of Pavarotti, is the home city of Osteria Francescana, that is ranked among the best restaurants in the world for, I don't know, 20 years. The chef Maximo Bottura, that is one of the best since ever. All in Modena. And the course is always on the weekend of the Grand Prix Formula One. So next Sunday, the course is Friday, Saturday, and next Sunday is the Grand Prix. The course is called iOS Festival and Formula One VIP Experience, because we're gonna visit the Ferrari factory on Thursday. We're gonna visit the museum on Friday morning. We're gonna visit the private track from Ferrari. We're gonna drive the Ferrari cars, Lamborghinis and Maseratis ourselves with professional drivers with us at 250 per hour. We're gonna simulate a real pit stop with real Formula One car drivers. We're gonna change the tires and all the thing. We're gonna practice on real Formula One simulators and experience the level of simulators that we have today. We're gonna have a dinner, on a special VIP dinner that very few people can book, inside the Ferrari Museum, among the cars, in the middle of the cars, the most exquisite, unique Ferrari cars in history. We're gonna have amazing after dinner parties at the rooftop in some of the best hotels in Modena. We're going to have a gala dinner at the Pavarotti Mansion and Pavarotti Museum. That is an amazing place with amazing food from some of the best restaurants. And we're going to have a special package, VIP, for the Formula One on Saturday for the practice, for the, how do you call on the Saturday when they're timing to see who's going to, the Saturdays, the pre-race competition to see who starts first.
Yeah.
The qualifiers, yeah. The qualifiers on Saturday, VIP package at boxes over the boxes, and the Sunday race VIP package as well. That's the program. So that's why the course is called Intraoral Scanner Festival and F1 VIP Experience.
That is amazing. Now, the problem is, number one, I'm not coming. That's a problem.
Next year.
Next year. So by the time this airs, most likely this will have already happened. So Christian, if I'm listening, how do I find out about this next year? Can I go to the DSD website?
Thursday, Friday on 2025 May, on the weekend of the Formula One. You cannot miss.
Love it.
The weekend of the Formula One next year in Monza, the Italian Grand Prix, right? The Italian Grand Prix in Monza. That's the weekend where the course is going to happen, always on the same weekend.
It's an amazing opportunity. I think you have to go if you're listening. Why wouldn't you go? So, Christian, thank you so much. We're going to have links to everything Christian has mentioned down in the show notes. So if you're listening, you can flip right up to the show notes. You can click a link and you can follow along. And you can also check it out for next year. So I highly recommend it. So Christian, thank you as always. I really appreciate it, my friend. So stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show. Hey, if you enjoyed it today, which I know you did, do us a favor, hit the share button, share this with your friends. Keep sending us suggestions for things you guys want to see. You're going to see we're lining them up for this summer. We have an incredible lineup right in front of us. And until we see you guys next time, or you hear from us next time, keep watching, keep listening to the Best Practices Show. You guys enjoy your day. Christian, that was outstanding. All right, hold on real quick. I want you to do an intro for Coffee Break with Coachman.
And 3, 2, 1, and we are back with Coffee Break with Coachman, with me, Christian Coachman, and my dear friend, Kirk Behrendt. And today, an important topic, speaking as a technician, the 15 major nightmares that we in the lab are suffering with your scans. What are the 15 major limitations, problems, and mistakes that we are doing as clinicians that are harming the quality of the information that we are sending back to the lab, so our lab can continue with the work and give us the best final restorative possible outcome?
Perfect. That was perfect. Good work. Good. All right. Anything else I can do for you, my friend?
Well, there's a lot of information.
That was excellent, though. Excellent. When you're on a roll, we're just going to go. Just keep going, man. So you can tell Patricia and John, I still have some files to upload. I will do that this week, so you get the rest of those. Just a lot of good stuff. So we resume on June 4th. Let me know if and who you want as a guest, or if you want to just do it ours. And I can reach out to the list I have too. So it's up to you.
Okay.
Give some thought to that. Okay.
Perfect.
All right. All right, my friend. Enjoy your day. Okay.
You too. Bye-bye.
All right. Thank you, everyone. Bye-bye.
Thank you.